So good morning, everybody. Thank you for attending our symposium on language, health, and well-being. I am Wayan Arga, a linguist from CHL, the School of Culture, History, and Language, College of Asia and the Pacific at the ANU. I am a member of this organizing committee, and on behalf of the organizing committee, I want to thank all of the speakers, including the invited speakers today. They come from across the world for your participation. We have an excellent program with interesting topics on the interconnection of language, health, and well-being from different disciplinary perspectives. Most of the sessions are in the afternoon from today and tomorrow also and on Friday. We want to thank all of the professional staff here at our school for their excellent support during the planning process and also the publicity of this flagship program. Now let me invite Professor Simon Haberle, director of our school, to give a welcome and acknowledgement to the country, and then a brief opening remark, officially opening this flagship event. Over to you, Simon.
Thanks so much, Juan, and welcome everybody. It's such a wonderful event to be a part of, and it really is a timely and very topical event to be hosting at the moment. And this workshop and seminars we're going to be hearing over the next few days on interdisciplinary perspectives on language, health, and well-being in Asia and the Pacific. It's a great initiative that the organising committee have brought together, and they've managed to bring together some really wonderful participants from locally and across Australia and around the world. So welcome to everybody here. And as is tradition for opening such an event, I'd first really like to acknowledge the traditional owners on the lands in which we meet. And for people out there, this can be many different traditional owners. For us here in Canberra, it's the Ngunnawal people who have lived and worked and essentially owned the lands on which we meet for many tens of thousands of years. And we acknowledge that and pay respects to the elders past, present, and emerging. And wherever you are sitting, we offer that same acknowledgement to traditional owners in that area as well. And to this seminar series, it's part of a broader language flagship, which is part of our School of Culture, History and Language. Language being a really wonderful part of our school. Some 16 different languages are taught, Asian Pacific languages, and a really vibrant academic community here, looking at not just the languages, but the cultures and histories associated with peoples in this region. It's a wonderful school to be a part of and to be a director of as well. And this flagship really exemplifies some of the great work going on and the thinking that's going on in our school and beyond the school. So thank you for attending. I really look forward to the talks that are happening today and the next couple of days, and all the best with the meeting. Back to you, Nara, I think.
Yeah, thank you, Simon. Now I invite Nara to chair our first invited talk by Professor Marta Hanson. Over to you, Nara.
Yes, thank you, Simon, and thank you, Wayan. So our first plenary session will be given by Professor Marta Hanson. I would like to briefly introduce Professor Marta. Professor Marta Hanson is Associate Professor at the History of East Asian Medicine in Department of the History of Medicine, Johns Hopkins University. And before that, she had taught at the University of California, San Diego. And her first monograph is on speaking of epidemics in Chinese medicine, disease and the geographic imagination in late imperial China, which has been really broadly read. and she was senior editor of Journal of Asian Medicine, Tradition and Modernity. She was also president of the International Society for History of East Asian Science, Technology, and Medicine. So within Chinese history, she is currently writing a book titled Grasping Heaven and Earth. What a title. The Healer's Body as a Technology in Classical Chinese Medicine. So we are very much honored to have Professor Hanson today to give our first session of the talks. Yes, please please join me in welcoming Professor Hanson. Yes, Marta, now over to you.
Thank you so much, Nora. I have, of course, learned about you and your work through Fluid Matters. So it's really such a pleasure and an honor to have you invite me to participate in this very interesting and interdisciplinary meeting. I have had a chance to read everybody's abstracts, and I'm hoping to participate later. And it's a real honor, as much as I can with the time difference. And it's a real honor to be opening with today's keynote address. I'm going to share the screen now, as we did before. And should be able to see that. So I first wanted to say that as soon as the pandemic really hit, many of the historians of medicine, like myself, were asked to respond. And one of the things that responded to, for example, I'll just give you a little bit of a personal trajectory about how I ended up writing an opinion piece called From Sick Man of Asia to Sick Uncle Sam, and then how it relates to this talk focusing on the Chinese medicine and COVID-19. So the American Association of the History of Medicine had its meeting in actually May, and I was on the committee. And as soon as we had to decide that we couldn't have it in person on the board, other historians picked up the baton and created an online version for in replacement of this annual meeting we have of historians of medicine. It's called Creating a Usable Past, Epidemic History, COVID-19 and the Future of Health. It's available online. I actually include a lot of URLs in this slideshow, and you're welcome to have it afterwards, of course. I mean, this is being recorded. But what really struck me is a talk by my colleague Ruth Vergasky on pandemic legacies and the future of health. She's one of the only East Asianists to present, but she made a basically an argument that synthesized work that many of our colleagues have done, basically saying that the Chinese, certainly East Asian countries, had been dealing with epidemics in the wake of Western imperialism, and that this is a necessary background for understanding the ability to control COVID-19 in East Asia.
Excuse me, Marta.
Yes?
So we have this the screen sharing of your notes rather than your slides. Is that?
Oh dear. Okay, so let's be.
Okay,
oh dear. That's okay. I have to get on it. Oh, stop share. How did that happen? Oh well, that's what happens when you try to change things a little bit from what you normally do. So let me pause. Sorry. I thank you for letting me know that. I will move to desktop 3. Okay, so how is, that should be okay now? Yeah, okay, sorry about that. So I just quickly, she talked about the major East-West reversal. And then shortly after that, I was asked, like many of my colleagues, to have an opinion about our present moment to bring my perspective on the history of epidemics and disease in the region on our current pandemic present. And I ended up writing an opinion piece, which is here listed at the bottom, the old and new sick men, but the title is From Sick Men of Asia to Sick Uncle Sam. And what I'm going to review here and set up what I'm going to say about TCM and SARS response, TCM for SARS and then for COVID-19. I'll be concluding with differences that I see in the different responses using traditional medicine in the Chinese context for SARS and then now COVID-19. But first I want to set up how I, see if this is how I thought about the pandemic present in terms of, well, language and metaphor and monikers, which I think are directly related to the theme of this conference. So that's why I'm summing up this current history opinion piece, and which will set up my perspective on how to think about the use of traditional medicines in such crises. So we have here first the legacies of late Qing China, which I think are absolutely important to understand this moniker. So sick man of Far East became used in the 1890s to understand how the Chinese Empire become ineffective in Western eyes, combination of war, foreign incursions, diseases, opium addiction. And then they borrowed this trope from an earlier one, sick man of Europe, applied to the Ottoman Empire. Now, some of you in East Asian history and culture may well know this trope, or maybe all of you based in Australia, but I don't want to assume that you understand its history. I'm going to present it here, that the sick man of Europe came out of Crimean War context, and it's attributed to Tsar Nicholas I, who said this quote, referring to the Ottoman Empire, at the time, to which the British ambassador is quoted as saying, well, Your Majesty says the man is sick, that is Turkey or the Ottoman Empire, is very true, but Your Majesty will deign to excuse me if I remark that it is part of the generous and strong man to treat with gentleness the sick and the feeble man, which wasn't really what happened. So we see here in 1896, editorial by the head editorial cartoonist of Punch magazine, a satirical journal out of England, where you see the Sultan Abdul Hamid in front of a poster announcing the reorganization of his own his own empire by Russia, France, and England into a limited company. And we see here, I think, a clear indication that his weapon is, symbolizing his own impotence in the matter. Now, this trope carried on in the North China Herald in the 19th century, late 19th century, by Westerners toward China. And we see it being used in this article, one of the early references to the same moniker, referring as a means to talk about all the ails that they found in China as a nation at the time, which I summed up here. And it's interesting that the same editorial cartoonist picked up that baton that went over from Europe, sick man of Europe to sick man of the Far East, in this editorial cartoon in 1898, where you have the Sultan cheerily saying to the Emperor of China, "Going to pieces, old man, nonsense. All you want is a dose of Consort of Europe." And presumably, that's he's wearing European costume and only has to hold a crutch on one hand rather than, underneath both armpits on a teetering position. So you definitely get the impression that the Qing Empire with sick man Far East is about to topple over. And we see the New York Times picking this up as well in reference to arguments that the Secretary of State at the time, John Hay, had been instrumental in keeping China's national sovereignty in the case of after the Russo-Japanese War, and was involved in these negotiations. So that's kind of an example of that trope, moniker. And I want to transition here to the East-West role reversal. So what I mean by that is that you have a major, difference in the response to COVID-19, which now that I was writing this article in end of May, June, and published in early September. But now, of course, it's very clear that there's a role reversal. And I think one important factor is the response to SARS and its, and certainly MERS, so coronavirus experience in the region. But also I'd like to take a longue durée perspective as well, in which the entire region was dealing with pandemics, first cholera and then plague, cholera coming in certainly on the backs of the Europeans in the area, in the Pacific Rim, and then a plague pandemic emerging from Yunnan, spreading to Hong Kong, and then becoming a worldwide problem after this outbreak in Hong Kong and then 1900s. So I think we really need to look at the differential response, success and clear failures from the US perspective in this longue durée. And I just list this kind of arguments that I make about this, that this larger experience, not just with coronaviruses since SARS, but also with epidemics and the resulting nation state systems that are developed, help explain why, despite all the different languages, cultures, national histories, et cetera, and healthcare systems, you know, democratic, autocratic, different political systems, that collectively East Asia has been in greater success than really arguably the rest of the world. I want to highlight this article by Andrew Selman, because I do think in many ways it's really good, but there's a critique I want to get to at the end that relates to the focus on today's talk on Chinese traditional Chinese medicine used in responding to COVID-19. And the problems with this article of leaving that out. So first of all, I want to highlight that early on, he had very good insights that I have relied on and find very worth reviewing and sharing with others about how, despite different government systems, you have some similarities along other lines that he writes out very clearly for these countries in the region. And he also in part 2 compared these different dimensions of it, which I think, well, there's so much to say about where the U.S. is lacking in terms of leadership and policy and manufacturing capacity, et cetera, which we don't need to go into, but helps explain this major differential as well. But one of the things he brought up, which I did find insightful as well, is this pervasive Western sense of cultural superiority that contributes to arrogance toward Eastern models and ignorance of East Asian history and the region's modern healthcare systems. And I think this is so true. I actually had a colleague who's runs emergency room, was in Maryland, now in New Jersey, infectious disease expert. He went to Singapore to teach his Singaporean colleagues about controlling infectious disease. And as soon as he landed there and started, you know, to talk, he realized he had more to learn from his Singaporean colleagues than they from him. So I think, you know, he shared with me that he had his own arrogance and was really kind of put in his place about how advanced really infectious disease experts were in Singapore and in the region. So why East beat West in COVID-19, however, in this article, Salman completely neglected the traditional medical systems, despite that in South Korea, they're separate disciplines than biomedicine, and it was not promoted by the state, actually. There's lots of evidence that amongst traditional Korean medical practitioners that they were filling in the gaps of certainly taking care of patients who were sent home and setting up telemedicine centers, et cetera. There's a publication that I've reviewed that's coming out on that phenomenon. In Japan, another publication by a colleague of mine on how Campo was being used in different clinics privately, again, not supported by, you know, not top down, but bottom up. And they have a different system where Western MD physicians are only allowed to, but they are trained in Campo pharmaceuticals. Taiwan, separate discipline from biomedicine, but still were involved in some treatments of COVID patients, and in China, really different support of Chinese medicine, but still subordinated to biomedicine. But in this case, definitely with COVID-19, we had top-down support as early as February through March. And I will get to that, come back to this. But one of the things I wanted to bring out is, like, why did Salman just completely ignore this dimension of the history? And I think this is something that I brought to light in response to what was happening in terms of the media coverage of traditional Chinese medicine use for SARS. And I think that the situation between what we know about what was happening in the Chinese mainland response to SARS in terms of enrolling the traditional medical practitioners and what we know about COVID-19 are night and day. We're just in completely different media realities. At this time, I think it was one of the first articles in this chapter in English really explaining this phenomenon. So my analytical concepts, let's say, that I want to introduce you to is one between conceptual blind spots and the other one media blindfolds. So what I find in Andrew Selman's work is maybe a media blindfold where he doesn't think it's important to discuss the traditional Chinese medicine or traditional medicine in Korea or Japan and other East Asian contexts, or he just has a blind spot there. So the metaphor of the blind spot is basically, I'm quoting here, a phenomenon where people don't know what they don't know. So that's a really an epistemological problem, right? And I find it ethically justifiable. But a media blindfold is something different. It's when authors choose to overlook something and they ignore something, they consciously disregard facts. And in the SARS case, what I was bringing to light was what was actually happening in hospitals. And not, what was being covered by the media of what they argued were Chinese drugstores and pharmaceutical companies taking advantage of people's fears of SARS, rather than really looking at what was happening in the hospital wards, where we know now over 50% of patients receive some form of integrated care. And so I think in this article, I brought, at least tried to make clear to people that what's important is to understand when these blindfolds affect what we're able to see about what's really happening in other countries of different languages and different media coverage. It doesn't get conveyed into English in a way that I think is balanced or symmetric. And so I concluded here about how what's more interesting and what we should be focusing on is this part, what were they thinking when they administered integrated treatments to their patients, and how did they get there historically, sociologically, and practically? And so like I said, I don't assume anybody has read that or my book. I did conclude with the end of my book on the case of TCM and SARS, and one of my main arguments was, why do these older nosologies and treatments continue to persist in the modern world? And my response was because they're forms of resistance and because those disease categories legitimate therapeutic strategies that people find not just meaningful, but effective. And we'll come back to that way of thinking about the response to COVID-19 in the Chinese medical communities in mainland China. So coming back to the East-West role reversal, this became very clear in the US. I'm going to go quickly through this in late June. And we see, really the inability to carry out this public health infrastructure and a federal level of lack of support, because they didn't, they kept arguing that the greater numbers is just due to testing, not because of greater infection and all of this kind of nonsense. So I don't think I'm saying anything new. You've probably had good coverage of what's been happening in the United States. What I want to share with you is this Hopkins map, which, if you don't know this resource, it's really been very, very useful for people all around the world. when I first started to talk about my research here, the paper I gave, the opinion I gave, and arguments here, we were we're not quite at 200,000 deaths in the US. When I gave it again a month later, we were at 225. And of course, now today we're over 250,000. And I want to give you some comparison of what that means in terms of fatalities. We're well over the collective fatalities of World War I, Korean War, and Vietnam War, and we're closely approaching the total military fatalities of World War II. And I think we're heading toward, in the new year, toward what was the estimated deaths of the last, major pandemic in the US, the influenza pandemic in 1918 and 1919. So just to give you a context of that global spread and the deaths estimated between 50 to 100 million. Now, it's shocking that 50 million, we have this range of 50 to 100 million. And I think Laura Spinney in this book that came out, and actually 2017, right before the 100th anniversary, she said, why is this huge gap in accounting for the dead? Why is this called the forgotten epidemic? Well, the infrastructures were stretched beyond capacity, so they even lost ability to fully account for the dead. And the people were so traumatized by the double hit of World War I and losing their loved ones, they needed to survive and rebuild their lives. I think we're sitting in a situation, at least I was in a position when I was reading this book and writing these papers, where I had a federal government that didn't want to have an accounting of, did not want to make visible the actual numbers. And so there's a lot of motivation in many different political sectors not to have things fully visible, which I find, of course, particularly egregious. And actually, there's a lot of deaths that aren't accounted for. I actually, I'm doing a review on reading to our pandemic present. And so I wanted to find out about my own family experience with the influenza pandemic, and was recalled by my aunt that my grandmother was only 7 at the time and was blamed for the death of her aunt. In October, she went to town with her mother. They lived up in a farm in north of Minneapolis. They went into town in October, just at things were reaching a peak in Minneapolis, where my family's from, and went back and stopped off at her aunt's house because they were on the train line waiting for her father to pick her up. And then the husband, her aunt ended up dying, and was her uncle, completely separated from the family, blamed my grandmother. And she actually, what's amazing is she never wrote this in her memoir. She wrote about going to Minneapolis to have her accompany her mother, who had just cut her hand with a needle. But she never talked about being blamed for the death of her aunt until she was in her late 90s. And she carried that grief to the end. And this just gives you, one family, my personal family's history, just take that globally. How people were not, why is it a forgotten epidemic? Why wasn't it recorded? And I am sure that my great aunt was not one of the numbers included for the influenza deaths of, because she was in rural Minnesota for that period. So she wasn't accounted for either. Okay, now moving to part 3, what do I mean by powerful discourses of weakness? So this develops from work of Ivo Amalong and other scholars in Europe that I've been reading of modern 20th century history, where there's certain power in certain categories of weakness. And certainly this sick man metaphor has a power to take something really unwieldy, like a nation, and make it, personify it, and also the US government in this case, Uncle Sam, and make something unwieldy into something that can be better understood. And the sick man label allows for a certain diagnosis that you can then act upon. And I was thinking about the title of the article, and thought sick Uncle Sam was very much appropriate for our present, dystopic present. And I found very early on that there's an editorial cartoonist who also thought of using Sick Uncle Sam here with the la grippe, or the grip, kind of pleurisy, an attack of the side. And here you have examples actually of, actually it's a critique of the fiscal policy of Andrew Jackson that was carried on by his successor, Van Buren. So it's a political satire of the effects of the Great Economic Panic in the US in 1837. And the editorial cartoonist blames Jackson and Van Buren for having tried to deal with the problem by barring the use of paper money and limiting money to specie or coin as the only legal tender. And even today, economists blame this major economic crisis of 1837 to that failed policy. And you can see how he's playing with that economic problem through the metaphor of medicines and the sick Uncle Sam. He even has the bald eagle here on the right saying, "I'll need to fly to the Flores for I shall be starved out here." And then there's a list of the financial failures in different cities. And brother Jonathan, who was considered at the time to be the everyday man in the US as a pair to the government Uncle Sam, says that he's going to have to get some money as well from Britain. So this metaphor continues today. There's several commentaries and publications I found that used it. First, worsening health of the US foreign policy, and also about the gridlock in Washington, which continues, of course, today. And even with the new Biden administration, we may not see an end to that in the near future. And even the economists talking about the coronavirus talk about Uncle Sam, sick Uncle Sam, vis-a-vis the coronavirus. So I find that this trope pejoratively positioned China as inferior to East Asia and neighbors and European counterparts, that is the sick man of Asia. But it also constituted a broader discourse that was really motivating in the 20th century world in China for national salvation, saving the country by science. It was linked to social Darwinism's idea of rise and fall of nations. And I actually think it wouldn't be a bad thing to acknowledge that we have a novel Corona King. It's a background Kelly Burke here that I ended saying, and this was actually drawn, and my publication was before Trump actually became a super spreader himself. And we had the big outbreak stemming from the Amy Coney Barrett announcement on the White House lawn, which is just, the more Republican senators, its staff, et cetera, it's just, and the rallies that Trump had before the election, of course, leading to, by a Stanford study, 30,000 infected and over 700 deaths so far. So we're clearly, I think, on the sick man of Asia side of things. And let me just exhale. All right. Now I want to just end my talk on picking up the thread again on the traditional Chinese medicine and COVID-19. So what I did argue in my current history opinion piece from Sick Man of Asia to Sick Uncle Sam was that if without regime change, there would be no interest in East Asian history models, dealing even from a biomedical standpoint, or certainly East Asian medicines. And I also highlighted that even Andrew Salomon, who in every other way, I think did an excellent review on the East-West role reversal, COVID-19 had neglected to cover this dimension. And I talk about that could be conceptual blind spot, or it could be a media blindfold, which I've already introduced to you, I consider to be worse. Now, I think one way to think about the role of complementary and alternative medicine, or Chinese medicine in the context of SARS and now of COVID-19, it's useful to think about it in terms of what Charles Rosenberg has called a shadow metaphor of allopathic or orthodox medicine. And I also highly encourage anybody who works in this area to revisit his to read his article, anybody interested. I think he has a really good, he himself doesn't take alternative medicine or complementary medicine. He even disavows it in his, as an author, saying that he doesn't support it, but he just is interested in the phenomenon of what the CAM reveals about Orthodox medicine. So I find it useful in the way he says, it's an index to the social and cultural geography of regular medicine. It illuminates needs unaddressed in our healthcare system and aspects of our system not easily reduced to that which can be validated, measured, expressed in data-driven algorithms. And he comes up with 7 factors for patronage of CAM. And I also find these useful to think about when, for example, mainland China decides to sponsor top-down use of Chinese medicine for acute infectious diseases like SARS and then now COVID-19. But these are other dimensions that he brought out, which I won't read here. You get an idea that people go to to CAM care because of various sense of dissatisfaction with the other systems of medicine available to them, and a different range of reasons. Now, moving to the story of Chinese medicine and COVID-19, I first want to say that there is a really good book out now about what actually happened at the clinical level, translations of the main texts and the main physicians involved, the kind of treatment protocols, acupuncture protocols, prevention protocols, etc., even press conference materials by practitioners based in mainland China, Shelley Oakes and Thomas Avery Garand. And if you want to, their book is available online. If you'd like to hear a presentation, this is also a webinar on Asian medicines and COVID-19 that ISTAM sponsored just earlier on October 22nd. And I'm going to sum up some of the things that they presented in their talk that I found useful for setting things up here. There was major mobilization. This gives you some sense of the financial commitment that was made at the state level for dealing with the outbreak in Wuhan, and the kind of money that was outlaid. But what I want to call your attention to is that there were almost 5,000 Chinese medical personnel that were also sent along with the 42,000 Western trained medical personnel. So there was, from the beginning, the role of Chinese medical trained personnel. And this is the thing that carries from SARS as well. They were all hands on deck, basically, and they were also called in to treat and help with controlling the SARS epidemic, which I did write about in the chapter published in 2010 that I introduced to you before. And the other thing they brought, I think I went too fast. So there's also the bottom-up cooperation participation dimension. And much of this Andrew Solomon summarized as well. Is really different response than we find in the US today. So there's a necessity and medical reasoning behind the state rules, fear and aversion to the disease, concerns about expenses, etc. Some sense of sacrificing oneself for the greater good, which we see generally. There's a lot of, this is comparable here, but a lot of resistance to it. Actually, it's not at all comparable here. I would say that individual liberty and private rights to just make one's own decision is really reigning here. And certain other dimensions that both Dr. Oakes and Garin brought up, and that there was why the Chinese state promoted TCM very early on, and these are 3 major dimensions of it. I know I'm going to finish shortly. I just don't want to assume that anybody knows what the timeline is for this relationship. So I summed up some major moments in that history. So as early as February 5th, you have a recommendation from the Chinese National Health Commission to use Chinese medicine with antiretroviral drugs. And this move is developing completely in accord with what happened during the SARS epidemic. And then we have them using even comparable prescriptions to clear the lungs that we find earlier. And then you have these medical personnel going to help up to actually 4,900, according to Dr. Oakes and Garen's work. And we have actual reports from the Chinese press about which medicines should be used. And I summed up this points already in the discussion in China Daily. And even what was really completely different from what happened with SARS is an effort to send formulas to Italy and to Africa, which then in Western media response was completely negative. So what we find here is coverage of these practices, but presented in a very skeptical way. And especially Breitbart, for example, very right-wing press. Steve Bannon, you may know or not know, was an editor there before he got on Trump's team. But they argue that this is only meant to enrich the Chinese state and peddling ineffective products overseas, which builds on arguments that I also saw for criticizing TCM treatment of SARS. And we see that it's typical. These are very typical attitudes, and I actually can understand them, but I want to place them in a 100-year perspective. You had in the major outbreak in Hong Kong, even when Western medicine had no cures for the patients, which we see also with SARS and we see with COVID-19, and Chinese were flocking to their get Chinese treatments in opposition to Western quarantine. There was major criticism from Western doctors of this, and Chinese moved the hospital so that they could still go there. And the same thing in 1911, but here we have actual, not the same thing, actually a really different response where you have public health changes in terms of masking, very famously Wulian did masking and cremation of bodies, and quarantines established that did actually help stop the spread of that epidemic. And of course, by that time they had a very clear sense of how it was transmitted. But still no viable therapeutics on either side. And I think the same was true for 1918 H1N1 in China, which I still think research should be done on. So it's understandable, the skepticism. I get it. I think going back to Rosenberg's article, these formulas are not tested with the gold standard or RCTs, randomized controlled trials, that are considered to be the gold standard for pharmaceutical efficacy. They're very difficult to standardize because there's a synergistic effect of multiple drugs, right? And the rationales of how the formulas are understood are in completely incommensurable system, different disease categories that legitimate different therapeutic strategies and come out of a very different history. So I've argued that medical bilingualism may be a concept that can help bridge this conceptual misunderstanding. And that is to understand how physicians trained in Chinese medicine also are operating fully in a modern biomedical system. So they toggle back and forth. And Eric Harchmer, Volker Scheid, other anthropologists of medicine in China have clearly demonstrated that this is the case. So I like to use this illustration, which anybody who's read Hisa Kuriyama's Expressiveness of the Body will understand, as illustrating two animals. I always see a rabbit, but if I make effort, I can see the duck. But you can't see the duck and the rabbit at the same time. So I use it as a way of understanding this incommensurability of the systems, but if you think about them as linguistically different systems, that you can learn one language and the other and become bilingual in them, then you understand the duck and rabbit metaphor that I'm applying here for medical bilingualism. I'm about to end here, and so I do haven't, again, I don't have anybody's read any of my work. I'm not going to read what I argued here, but basically I said that even though Du Youyou's discovery of artemisinin was firmly placed in a biomedical model, that it actually, they were giving her the award for having saved so many lives. Nonetheless, she came out of a a bilingual institution at the Chinese Academy of Traditional Chinese Medicine, where she was encouraged during the Vietnam War and later to look at the Chinese traditional knowledge and find some efficacious material substances from that, which she then transformed through organic chemistry. So one of the things I'd like people to think about is that they're operating in a bilingual way for SARS and COVID-19. That is the TCM trained physicians. So they clearly understand germ theory and how antivirals work, and they also understand the Chinese logic for these different formulas that are meant to help the lungs to deal with these infections. So what I see, just to wrap up, coming to the end, you have really different responses that I'm working on writing this up, but they're very different. Like in the SARS case, they say just maybe 52% of the patients were treated with integrated medicine. This is from the World Health Organization assessment. But now they're saying over, 85%, so over 90% were treated with integrated medicine. They never sent herbal formulas outside of mainland China. And certainly this is the case in COVID-19, which has been criticized from the Western media press, but nonetheless is a fact. And this, I think, relates to a very different globally integrated world than it was just back in 2002, 2003. And now we're seeing major failures of other governments to respond in contrast to East Asian colleagues and their governments. So this is, the other important point is that Chinese medicine and Tibetan medicine is being used outside of China. And this is a presentation that was given at the ISM meeting last month on Tibetan medicine being used in the US to treat COVID patients. And so we're really in a different world in terms of the case of TCM and SARS and TCM and COVID-19. I highly recommend people read this essay by Helen Tilley, anthropologist, Cambridge University, in which she gives a kind of longue durée history of traditional medicine more broadly, not just in East Asia, and has a really nice way of breaking things down into different dimensions of how they were, how they understood. But she gives an analytical concept of polyglot therapeutics, which I find really useful to think about in terms of my idea of medical bilingualism. So I will leave with this conclusion that I think I find it really meaningful to make these phenomena known more broadly in English. That is the use of traditional medicines for treating acute infectious diseases and particularly COVID-19. We have an opportunity, and these are papers in this very conference that I'm very eager to hear, to write this history now. And not let it be, these dimensions be forgotten, as obviously many dimensions of influenza pandemic 100 years ago were. Thank you. That's it. I'm very pleased to be part of this meeting. I got a clap. So please, anybody would like to ask questions, or I know I went through a lot of things pretty quickly.
Is there any questions? So Nara seems to be around, not sure where Nara is now. Okay, is there any questions or comments?
I have a question.
I wonder.
Okay.
Hi, Natasha. It's nice to put a face to your name.
Oh, hi. You were saying about there's quite a gap in our knowledge about the deaths during the 1918 influenza pandemic. I was just wondering if you could speak a bit about the Chinese, whether there was documentation of that influenza epidemic in the Chinese literature and how they may have responded to that?
So I find that topic so fascinating and so understudied, and I have started to collect materials in the press available, of the time that covered it, and there are some articles in Chinese, but there isn't a good overview of, for example, what treatments were being used and how were they understood, and that it's hard to find the records on that, actually the specificities of what people were taking. And but I do have I have an extensive bibliography. I have a draft I've made because I want to respond to this lacuna in scholarship, and actually right now, I was writing it for the 100th anniversary before this pandemic. So now, of course, Natasha, I'm even more motivated to do that. But what we do know that like other places around the world, there was well, it seems that according to the Chinese scholarship at the time, they felt they were dealing with it better, and that they didn't have as high mortality rates as other parts of the world. And they credit it with the traditional therapies, but it's really difficult to get at that. Like, what do they mean by the traditional therapy? Like, what formulas, I'm still I have some hints at that, but I don't have, the evidence hasn't been satisfactory for me to answer that. And then,
I'm also wondering whether it's about prevention, a different kind of prevention strategies, because, the prevention was very different in China, say, with the response to COVID than as opposed to the US. And yeah. Well,
that actually what is coming. Your question is bringing many things up to the front burner. And one of the Chinese articles I did read on this is arguing that they had greater exposure for many years before, and so this is part of the argument that the the influenza pandemic came out of China and was transmitted by Chinese migrants who were going across the United States to work behind the to be support for the Allies, actually, in the World War I context. And so that's why there's one argument, that's why there's an outbreak in Kansas in the US, for example. And on the Chinese scholarships, so these are complicated arguments, and there's a lot of hypotheticals, so I haven't published anything on this, I haven't worked it all out in my mind, but Laura Spinney's The Pale Rider, I think, is one of the best syntheses of these. The argument that the Chinese migrants brought it into the World War I arena, but she doesn't talk about the Chinese language scholarship, that there were many outbreaks before 1918 of flu-like symptoms that were being treated, and so they think that the population overall had greater resistance to it, and why they didn't have the same kind of mortalities that the rest of the world has. But then again, we don't have the statistics to. It's a very tantalizing research project, and it means that unsatisfying, because it's hard to really get the material to say anything definitive about it. But anyway, your question inspires me to just put out what I have on it. I was going to co-author with a colleague of mine, Michael Liu, which many of you may know, works on public health in the 19th, 20th century Taiwan and in the Pacific arena. So I thought with his help, the two of us. Well, now I'm really motivated to get that out. So thanks, Natasha. Whether or not I'm wrong, or right, I can at least make a synthesis that no one else has made quite yet on the topic, that I think really needs to be examined, and certainly in light of the arguments I've made of Chinese medicine response to Chinese medicine response to SARS and COVID.
Well, thanks for a really interesting talk.
Thanks for coming. Thanks for your question.
Jane?
I've got a question, and it relates to whether you think this East-West divide is actually a useful notion, and whether, in fact, some other distinction might be relevant. Because after all, the second highest cases are in India, which are usually considered part of the East, and secondly, in of Anglophone countries, at least, Australia and New Zealand have got an excellent record in not, having
your criticism is
my third point is, do you think, for instance, The Economist's reaction to the touting of Chinese traditional medicines in Africa is equivalent to your president's touting of hydroxychloroquine? That in both cases you have what is considered by global science unproven treatments being, peddled to people outside that culture. So, yeah.
So on the first question, on the first one, East and West, yes, absolutely. I think that I should to qualify that, I was drawing from the different. I guess I was it's a heuristic device, and I should be careful about that. But I appreciate the qualification, certainly in how why we consider Australia, New Zealand, Western part of the Western world is like complicated geographically. So that I completely accept that point. On the second one, I do not equate hydroxychloroquine and other quack medicines with Chinese medical therapies. I actually have to say I would take a position and think that's completely not an adequate analogy, because Chinese medical formulas are we could argue that nothing should be used unless it goes through randomized RCTs. The formulas do have a logic within. That's why I'm arguing within their linguistic system, a long empirical use of them. And actually, Chinese medicine before the 20th century was dominantly used to treat acute infectious diseases, which I've written a book about. And I just think it's important to think and understand about them being legitimated within a different linguistic system of knowledge that has its own traditions and its own logic that I definitely think is worth preserving and understanding on its own terms, historically and now politically. And I think to go on the other, like going from the rabbit to the duck, and that my analogy, I also am a both and kind of person. I think that we should apply evidence-based medicine to isolate pharmaceutically active agents in these formulas, like Du Yoyo did with artemisinin, for example. She actually then transformed it into a completely different compound. And so I'm somebody who is both an advocate of doing more evidence-based medicine and pharmaceutical trials, but also to understand that many of these formulas are they're complex formulas with synergistic effects, which can actually be understood now by science, and we should put more money into understanding them, but also understand as much as possible the ways that people think who are trained in these systems understand their efficacy. So that's, that can be opinion that other people would disagree with me, but I've been writing about it for 20 years and stand by that. So I really appreciate you, bringing those 2 points up, so I could clarify my position on both.
Okay, our next question is Carol. Carol, would you like to raise your question, please?
Hi, thank you very much. That was really interesting. I'm from the ANU working in Japanese studies, but I have a linguistic question for you. I've been looking at some of the terminology used in the Japanese press for talking about COVID, and there's a lot of use of katakana, which is a phonetic script that is used to represent words they're taking from English, like social distance and stay.
Yeah, I know, it's different from hiragana. Yeah, I've studied Japanese.
There's one, so say for example, something like overshoot. So to overshoot, I don't think is a word that's being used in the English press. It's a sporting metaphor for me. I was thinking of basketballs, missing, but it's used for massive increase in patients. So this sort of massive pandemic. And so there's been some discussion about older Japanese people not then understanding the katakana and that we need to use proper Japanese words, or that the traditional Japanese words, particularly really scientific words. This was also discussed in relation to the earthquakes and, you know, using scientific words about sort of, you know, nuclear stuff. And then there's also been discussion about the use of katakana being less scary, so that it makes it more of a global thing. To say pandemic sounds better than using a sort of heavy Chinese character-filled scientific word. So I just wondered what was happening in Chinese, whether there's been any discussion around, or in your comparison between those influenza epidemics and SARS through to now, is there a linguistic softening to globalize it, or a nationalizing of the, anyway, sorry, that's a very vague question.
So no, not at all. It's fascinating in terms of language. I would say there's two modes of translation that I see in your comments coming from your experience in Japan. One is domesticating and one is exoticizing. So the katakana is exoticizing, and then the domesticating is trying to find some native equivalent, right? And often some things get lost in translation. So scientificating, if that's a word, like medicalizing, making it sound more scientific, as opposed to making it sound less scary is another. Right, so I just find, as always, the Japanese situation is so different. It's not completely on its own cultural world than what I'm more familiar with in mainland China. So in the case for SARS and for COVID, you have both a neologism, you could say, like a term, well, not really neologism, but anyway, using a medical term for acute infectious disease of the lung. And also, so a term that's specific to SARS and also of COVID-19, that's definitely the case. But at the same time, in the Chinese medical community, so you could say a neologism was created to understand that's what I mean, a new term. It's not katakana, but a new combination of Chinese characters to signify that as them as unique disease concepts. But also what's very fascinating to me in my research is the persistence of the categories from the classical Chinese medicine. So this goes back to Jane, was that Jane's question, I guess? So that's, so they, both SARS and COVID-19 are part of wellbeing, which is a type of I just translate as warm disease, but they have to do with the acute febrile diseases that are characterized by fevers. And so because of that, they don't see these as new categories. These are, we see both of these diseases as newly emergent 21st century epidemics, then that became pandemic. Of course, COVID much more than SARS. But in the Chinese medicine way of understanding it, they are different permutations of acute febrile diseases that they have a long-standing tradition, thousands of years actually, going back to treatments from the coal damage treatise of the 2nd century AD, the end of the Han. So these therapeutics, I think, are of course have changed, but there's a long, like millennia of use of these formulas and understanding of how they help the lung deal with these kinds of inflammations. They understand excess heat, phlegm. This is considered a hot and phlegm disease that's then treated accordingly with different combinations of drugs. So that's why I think it is just not appropriate to equate them with hydroxychloroquine and other types of chronic medicine. I will stand by that, and people are welcome to disagree with me, but that's why one takes an argument, isn't it?
Yeah.
So, any other questions? I don't have anything in the chat. So, is there anyone who raised hands? If you have questions, try to look at everyone.
There is one on, on the chat box, in the chat box.
Yeah.
Nara?
Which one? From Maulini?
Yeah.
Maulimin? Yeah, Maulimin. Would you mind phrasing your question, please?
I could read it. I am reading it.
Unmute, please,
Yeah.
Maulimin.
Okay, my question is that it seems that some academician or scientists from Western cultures ignore the traditional or which is Asian or other cultures. Do you think that is it? What's that? Does it? Well, is it? Well, what to say? Do you think that it is true? I just want you to give some comments on this one, because sometimes on let's say to the press and something like that. Thank you.
So you mean this? Do you think it's part of ignorance or arrogance? Is that your question?
Yeah, because looking at the well, in some the press, let's say like in the press, that some people think that it should, let's say, to be scientific. They ignore the traditional cultures. What do you think of this? Whether it is because of the ignorance, of the arrogance, or some Western.
I think it's both. Yeah, I think actually, when I like to use the Andrew Salomon article because I think it's brilliant in so many ways. It was so early, mid-May when it came out, and he even brings out this dimension that many. Well, maybe I shouldn't use West, but Anglo-American, like the Europeans, and certainly from the U.S. perspective, and I will not speak for Australia and New Zealand, very much part of that, the Southeast Asian world, and connected with East Asia in so many ways. But I think that he had that insight. And he, is a significant part where we're just not paying attention to the longue durée history, which is one of the things I wanted to bring out of the over a century of dealing with epidemics coming in on the back of Western imperialism, certainly cholera, but other ones, and influenza, but also the recent experience with SARS, and also helped set up East Asian countries better. But it's a really nice overview of all the different multi-factors of why East Asia countries have been so much more successful overall, despite such vast differences in culture and public health care systems, and of course political systems. But so I think it's spot on. There is ignorance and there's also arrogance. But even in his own article, he doesn't cover at all the traditional medical response, even though there was some kind of response in all of the in Southeast Asia too, in Indonesia, I know. And, from family there, and all the other different responses that come out of practitioners who are not part of, that are coming out of traditional medicine. It's very much alive and well in the whole region. So I found that an interesting example. I don't know yet of a conceptual blind spot or a media blindfold. That's those are the terms that I brought up in my my article on the case of traditional Chinese medicine and SARS. But nonetheless, when you do look at the media that did cover it, it is very much negative press if they cover it, and they're covering it in a very skeptical way. Which I understand that the way that the Chinese government has been touting their success in a highly politicized way, and can also using the Chinese medicine as a form of propaganda. But at the same time, I think we should take seriously, what physicians are doing beside the bedside, and that there's, we should look at what they're doing for influenza, which, like, Natasha's question, I want to do better justice to it with my colleague. Certainly inspired by this conversation to do that. And what was happening in SARS, like how are clinicians thinking? Why, understanding that historically and politically and clinically actually too. And now we can understand COVID-19 and more people are involved, and we each actually have clinicians who are able to translate immediately. We're in a very different world in terms of media and understanding of it, of course, in the global spread of it. We're in a very different world. I want to emphasize that, but also our knowledge of it, of what's going on in terms of the traditional Chinese medical response. We have I feel a responsibility to have more people know about it. It's one of the reasons why I was so excited to be able to present, my little perspective on this phenomenon in this forum amongst you. It's my way of finding agency at a time of what I consider to be, and I think all of us, well, maybe not so much in Australia, but based in the US, find dystopic.
Okay, thank you so much, Professor Hanson.
Okay, is there any other question? So if you have a burning question, just only probably one question because we are running out of time. If not, I have a little question or comment, to add to Marta's point on Andrew Salmons. So he is so ignorant that even he missed, Mongolia from East Asia, you see, and Mongolia has been
I totally agree with you. Yes,
successful country in terms of dealing with the pandemic. Even though in the last few days has been changing a bit, but yes.
Yeah, he had his blind spot. Now that might be a blind spot, not a blindfold, like intentionally leaving it out. But yeah, I agree.
Yes.
So.
My just a quick question is, is there any, I must have, you might have already mentioned, but because I missed out a bit of your last bit of your talk because I had to do something urgent. Is there any, Chinese research trying to, analyze the Chinese traditional medicine, the substances of the medicine, herbal medicine itself, analyzing via bio.
Absolutely. Yes, absolutely. They are. Yes. And so, yeah, absolutely. So the thing is, one of the things, of course, we're all hoping for the vaccine, and the search for vaccine has been, rapidly enhanced beyond anybody's imagination. But I find before the vaccine comes through, in the absence of other, what is my response to that? We should encourage biomedical studies of these drugs, but also, like I said, I'm a both and kind of person, also try to understand and acknowledge the frameworks out of which these therapeutic strategies are understood and where they originated. So of course, most of my life has been devoted to the former, not the biomedical side, but I write about both. I mean, I find both phenomenon. I certainly lecture on how how things are translated into and become, statins come out of Chinese medicine. I have a whole lecture on all the different Chinese medical substances that have been transformed, or artemisinin, like with Du-Yo-Yo. I find that history, it also needs to be documented and understood. And I'm not somebody who thinks it has to be completely within a traditional classical way of understanding things. I like to toggle between the two worlds and make other people understand that these are linguistic realms and there's translation happening. And that's why I think this forum that you've organized is just so perfect for me to present my ideas for debate and discussion.
Yeah, great. We should continue this discussion in the future. So it was fantastic talk, and as you can see, it's really people are interested, and it's really the right time to discuss about this. And as you pointed out, we have to learn from each other. This is definitely there are a lot of people thinking about the biomedical knowledge is stagnant in many ways, and they have to actually open up for looking for some other ways to think. And the One Health ideas in the recent years, which has been developing, is really one aspect that people from the biomedicine are interested in looking at the other alternative way to include and to collaborating. Yeah, so it's really timely. And I hope that we will continue this discussion further in the future. And yes, and thank you very much. And
well, I'll try to come in as much as possible for the rest of the talks when I'm not asleep. But I've got a lineup, and I'm excited to come back in and listen to your and other people's work as well. So thanks for inviting me. I really am honored, and I learned as much from this conversation, and as I'm sure I'm going to learn from my colleagues during the rest of this conference. So thank you so much.
Yeah, thank you very much, and thank you also for our participants, and thank you for participation in the vigorous discussion. And our next session will start 1:30 Canberra time, unfortunately. So, and see you later, and thank you, Marta, again. And
it's been my pleasure. Thank you so much for inviting me. As I said, a very meaningful venue for me to present my little corner of the world. Bye. Bye, everybody.
Yes.
I'll see you later. I'll dip in when I can.
Sometime. Yeah.
Yes, you owe me a dinner.
Yes. Okay. Thank you very much. See you later.
Bye. Bye. I'll take a rain check on it.
Yeah, thank you.